Hi everyone! Today we'll be doing a high yield MSK review. Like the previous videos, I'll be mentioning a vignette, take a few seconds to pause, try to guess the answer, and let's get started. So first, we'll be doing some muscle injuries. So the first one is the most common rotator cuff injury. There's going to be trouble abducting the arm the first 15 degrees, and there's an abnormal empty and full can-test. So this is a supraspinatus muscle injury, and remember the nerve that innervates this muscle is the suprascapular nerve. Next, the patient's going to have trouble abducting 15 to 90 degrees. So this is a deltoid muscle injury, and remember the axillary nerve innervates this muscle. Next, the patient's going to have trouble abducting over 90 degrees and asymmetry of the shoulder blades after a chest tube placement or a breast surgery. So this is a serratus anterior muscle injury, and we call this winged scapula. And remember, the nerve here that innervates the muscle is the long thoracic nerve. And remember, the roots are C5, 6, and 7. Next, we're going to be talking about nerve injuries. So this one is affected in a fracture of the humerus neck, and it causes loss of sensation to over the deltoid region and the lateral arm. So this is an axillary nerve injury. And remember, the artery that runs with it is the posterior circumflex. Next, a patient's going to fracture the humerus midshaft and they develop a wrist drop. So this is a radial nerve injury, and it's associated with the deep brachial artery. Next, we're going to have a fracture of the distal humerus at the supracondylar region, and there's a loss of sensation over the thenar eminence and the lateral 3.5 fingers. So this is a medial nerve injury, and remember, this one is going to run with the brachial artery. Next, a baby is going to have an arm that's abducted, medially rotated, extended, and pronated, and it's due to a C5, C6 injury. So this is called Erb's palsy. Next, someone's going to develop a claw hand after upward first during childbirth or an adult grabbing a tree branch during a fall. And this is due to a C8 to T1 injury. And this is called Klumpke's palsy. And this is associated with a lower trunk injury versus Erb's palsy is an upper trunk injury. Next, we're going to have atrophy of the hand muscles, an extracervical rib, often seen on imaging, and compression of the scalene muscles. So this is thoracic outlet syndrome. Next, a patient's going to fall on outstretched hand. They're going to have pain by the thumb, and it can cause avascular necrosis. And this is a scaphoid fracture. So this is the most common fracture of the bones in the hand. And remember, the thumb side of the hand is called the thenar side. And another important thing is that the pain in this region by the thumb is called the anatomic snuff box. And we often have pain in this area when the scaphoid is fractured. Next, we have somebody who injures their hand after a fall and then develops carpal tunnel syndrome. So this is a lunate dislocation. And remember, carpal tunnel syndrome is explained by pain and numbness to the first 3 digits. And then you can also have issues with abduction and opposition of the thumb. Next, the patient is unable to extend the medial 2 fingers, and this is due to an ulnar claw caused by a distal ulnar nerve injury. Now we have a patient that can't close their lateral fingers when trying to make a fist. So this is hand of benediction due to a proximal median nerve injury. Next, we have a patient that can't extend their lateral fingers. So this is median claw due to a distal median nerve injury. And then we have a patient that can't close the medial fingers when trying to make a fist. So this is the OK gesture caused by a proximal ulnar nerve injury. Now remember, in distal nerve injuries, we're trying to get the patient to extend their digits, and issues here cause claw hands, versus in proximal injuries, you're trying to get the patient to flex and make a fist. Okay, and remember, issues with the lateral fingers are going to be due to median nerve injuries, and issues with the medial fingers are due to ulnar nerve injuries. Next, we have a nerve that's affected where you get burning, tingling in the suprapubic region after abdominal surgery. So this is the iliohypogastric nerve being affected. Next, we have a nerve injury that leads to decreased sensation to the medial and anterior thigh and an absent cremasteric reflex. So this is the genitofemoral nerve. Next, we have a female with high BMI that has decreased sensation to the anterior and lateral thigh. So this is the lateral femoral cutaneous nerve. And remember here, often people who are more obese wear tight clothing. It can compress this nerve and lead to decreased sensation in the anterior and lateral parts of the thigh. Next, we have a patient who's unable to extend the leg after a car accident, which causes anterior hip dislocation. The patient's going to have decreased patellar reflex, and the leg is externally rotated. So this is the femoral nerve being affected. Next, we have a patient with lower back pain radiating down one leg after a posterior hip dislocation, and the leg appears shorter and internally rotated. So this is the sciatic nerve. Next, we have trauma to the lateral leg, and now the patient is unable to pick up the foot while walking or feel the top of the foot. So this is the common fibular peroneal nerve that's affected. And remember, this nerve runs through the lateral leg where the fibular neck is, and so injuries to this region can lead to the issues with eversion, dorsiflexion, and sensation to the dorsum of the foot. Next, we have a patient with injury to the knee or to the ankle, and now they're unable to stand on the tiptoes or feel the sole of the foot. So this is a tibial nerve injury. So remember things like knee trauma, Baker cyst, and then also if the tarsal tunnel is affected lower down, these can all affect the tibial nerve, and you get issues with inversion, plantar flexion of the foot, and sensation is going to be lost at the sole of the foot, which is the bottom part of the foot. Okay, and the tibial nerve, and the last one we talked about, the common fibular peroneal nerve, are branches of the sciatic nerve. Next, we have a patient given an injection to the superomedial gluteal region, and standing on one leg leads to the pelvis dropping to the opposite side. So this is a superior gluteal nerve injury, and remember this finding of standing on one leg is called the Trendelenburg sign. Okay, and so the pelvis drops to the opposite side of the nerve injury. And so to prevent damage to this nerve, remember that you want to inject in the lateral quadrants of the glutes to prevent the nerve from getting damaged. Next, we have a patient with a posterior hip dislocation that develops difficulty climbing the stairs. So this is an inferior gluteal nerve injury. Next, we have a patient with decreased sensation to the genital area after childbirth, and a nerve block that we use an ischial spine for the landmark for the injection. So this is the pudendal nerve. And so remember that the pudendal nerve block is used during childbirth, and the ischial spine is used as a landmark. Okay, and injury to this area leads to loss of sensation in the perineum and the genital area, and it can also cause fecal and urinary incontinence if the external sphincters are damaged. Next, we have a patient with knee pain during soccer and the increased gliding of the tibia when the leg is pulled forward. So this is a ACL injury. Next, we have a patient who has injury to the knee and increased gliding of the tibia when the leg is pushed backwards. So this is a PCL injury. Okay, so for ACL injury, we use the anterior drawer sign, and for PCL injury, this is the posterior drawer sign. Next, we have a patient with knee injury and medial space widening of the tibia when you apply lateral force. So this is an MCL injury. Next, we have a patient who also has a knee injury, but this time they have lateral space widening of the tibia with medial force applied. This is an LCL injury. Next, we have a patient who has pain and popping on internal rotation and varus force. So this is a lateral meniscal tear. Next, we have a patient who has pain and popping on external rotation and valgus force. So this is a medial meniscus tear. Next is the most common ligament affected in an ankle sprain. This is the anterior talofibular ligament. Next, we have someone who comes in with pain on the inner part of their elbow. That's worse with repetitive wrist flexion like playing golf. So this is medial epicondylitis, and this is also known as golfer's elbow. Next, we have a patient who has pain on the outer part of their elbow. That's worse with repetitive wrist extension like playing tennis or badminton. So this is lateral epicondylitis, also known as tennis elbow. Next, there's a child who has shoulder drop after a fall. So this is a clavicle fracture. Now remember, in clavicle fractures, the proximal part is pulled up by the sternocleidomastoid and trapezius muscles, and the distal part is depressed due to the deltoid muscle. Next, we have a patient who has wrist pain after a long bike ride, and there's damage to the hook of hamate. So this is Guyon canal syndrome, which is an ulnar nerve compression. Next, we have a patient with numbness and pain in the first 3 digits, loss of thumb abduction and opposition, thenar atrophy, and percussion of wrist or flexion of the wrist causes tingling, which are known as positive Tinel and Fallon tests. So this is carpal tunnel syndrome. And remember, this is where the median nerve is entrapped and it causes the nerve compression leading to these symptoms. And you can see this in pregnancy, rheumatoid arthritis, hypothyroidism. So a lot of different conditions, even such as repetitive use of the hands, can cause carpal tunnel syndrome as well. Next, we have hand pain after punching someone in the face. So this is a 5th metacarpal neck fracture, also called boxer's fracture. So this is where you have a direct blow with a closed fist and you injure the 5th metacarpal neck. Next, you have somebody with sudden knee pain and swelling after injury in a soccer game. And three things happen here. There's an ACL injury, medial meniscus injury, and an MCL injury. This is an unhappy triad. Next, we have a painter or a maid who gets swelling and pain in front of the kneecap. So this is called prepatellar bursitis, and it's due to repetitive trauma or pressure from excessive kneeling, which is why painters and maids often get these symptoms. Next, we have swelling behind the knee in a patient with osteoarthritis or rheumatoid arthritis, and it can lead to tibial nerve injury. So this is a popliteal or Baker cyst. And just to connect to the last condition that we saw with a tibial nerve injury, you have issues with inversion and plantar flexion. Next, a new mother gets thumb pain, worse with movement, and physical exam reveals radial styloid tenderness. So this is decurvain tenosynovitis. And people that use their thumbs a lot, like new mothers lifting their babies, thumb texters, sports players, can all get this radial styloid tenderness. Next, we have a patient with swelling on the wrist or ankle that transilluminates, and it arises from degeneration of the periarticular tissue. So this is a ganglion cyst. Okay, and often this condition just resolves spontaneously. And the key thing here is that it transilluminates. Next, we have a runner who develops lateral knee pain. So this is iliotibial band syndrome. Next, we have a patient who has severe pain after a bone fracture, and you can't feel the pulses, the skin is pale, and there's numbness. So this is called limb compartment syndrome, and it's due to increased pressure in the fascial compartment. Okay, and so this can block blood flow and lead to these symptoms. And we call it the 5 Ps usually, which stand for pain, pallor, paresthesia, pulselessness, and paralysis. Next, we have a patient with heel pain, worse with first steps in the morning or after sitting for a long time. So this is plantar fasciitis, and it's inflammation of the plantar aponeurosis that causes these symptoms. Next, we have facial pain and a headache that worsens when opening the mouth. So this is a TMJ disorder. So the temporomandibular joint often is inflamed or injured, and sometimes you hear a clicking when the person's chewing, and it can lead to symptoms such as facial pain and headaches. Next, we have a child that starts crying after the parent picks them up, and they're holding their arm close to the body in a flexed and pronated position. So this is the radial head subluxation, also called nursemaid's elbow. And when you suddenly pull on the arm of a child, the annular ligament slips over the head of the radius, and it causes a lot of pain to the child, and they have these symptoms. Next, we have an athletic child that has knee pain, and there's tenderness over the tibial tubercle, and it's often due to quadriceps overuse. So this is called Osgood-Schlatter disease. And the key word here is the tibial tubercle tenderness. Next, we have a young female athlete who presents for anterior knee pain. So this is called patellofemoral syndrome. Next, we have a newborn baby that has a clunk on hip physical exam, and the diagnosis is confirmed with ultrasound. So this is called developmental dysplasia of the hip, and it's due to abnormal acetabulum development in newborns. And so the hip has this instability and dislocation, and you can hear this clunking sound on physical exam. Next, we have a child with hip pain and a limp, and it's chronic, and the initial x-ray can be normal. So this is leg Bursitis, and it's due to idiopathic avascular necrosis of the femoral head. Next, we have an obese child with hip or knee pain, and the x-ray shows the epiphysis displaced relative to the femoral neck. It looks like an ice cream slipping off the cone. So this is called slipped capital femoral epiphysis. So usually they'll mention a chubby kid who has some sort of pain, and you want to think about this condition. Next, we have a patient with short arms and legs, a normal size head. It's an FGFR3 activation mutation, and multiple family members are affected. So this is achondroplasia. Okay, remember the FGFR3 gain of function causes inhibition of the chondrocytes, which then prevent our extremities from growing. So, it's an autosomal dominant mutation, and the patients present as these dwarfs. Okay, next, we have an old frail lady with severe pain after a mild fall with normal calcium and phosphate levels. So this is osteoporosis. Next, we have a patient that has thick, dense bones that are prone to fractures due to defective osteoclasts. So this is osteopetrosis. Okay, the osteoclasts aren't working, and so there's abnormal bone resorption that lead to these really thick bones. And here, a bone marrow transplant is potentially curative because the osteoclasts are derived from the monocytes in the bone marrow. Next, we have an adult with weak bones and fractures, and labs show low calcium and high PTH levels. So this is osteomalacia, also known as vitamin D deficiency. Okay, and it leads to lack of mineralization of the bones, which lead to these really weak bones. Next, we have a child with bowed legs, prominent rib points, a soft skull, and the labs show low calcium and a high PTH. So this is called rickets. Okay, so if a child has vitamin D deficiency, we call it rickets. If an adult has a vitamin D deficiency, we call it osteomalacia. Next, we have a male with trouble hearing. His hat doesn't fit anymore. He has a high ALP, and it increases his risk of high output heart failure and osteosarcoma. So this is Paget's or Osteitis deformans. Next, we have a patient that has sickle cell disease, or a patient on steroids, or an alcoholic who presents with hip pain, and there's medial femoral circumflex artery insufficiency. So this is avascular necrosis of the femoral head. Next, we have a patient who's a young male with bony projection of the metaphysis, and it's covered by a cartilaginous cap. So this is osteochondroma. Next, we have a male with bone pain that's worse at night, and it's relieved with NSAIDs. So this is osteoid osteoma. Next, we have a young male with bone pain that's not responsive to NSAIDs. So this is osteoblastoma, and they always like to compare osteoid osteoma and osteoblastoma because it's very similar, but look out for the response to NSAIDs. And also, osteoblastomas tend to be larger than 2 centimeters in size versus osteoid osteomas are smaller. Next, we have a benign tumor of cartilage in the hands and feet. So this is a chondroma. Next, we have a patient who has knee pain, and imaging shows a soap bubble appearance. So this is a giant cell tumor. Next, we have a child with retinoblastoma, seen by a loss of the red reflex in the eye. Now they develop bone pain. Or we could have an elder male with Paget's who develops bone pain. It's often due to RBP53 mutation, and imaging is going to show a Codman triangle or a sunburst pattern. So this is osteosarcoma. Next, we have a tumor at the diaphysis. X-ray shows onion skinning pattern. There's a translocation of 1122, and histology is going to show small blue cells. So this is Ewing sarcoma. Next, we have a middle-aged female with over an hour of morning stiffness, symmetric joint pain, ulnar deviation of the hand, lumps on the hand or arm, and imaging shows erosion of the bone. So this is rheumatoid arthritis. This is an autoimmune condition, and the antibodies here are rheumatoid factor and anti-CCP. Next, we have an elder female with joint pain worse with activity, bone deformity of the DIP and PIP hand joints, and imaging is going to show joint space narrowing, subchondral sclerosis, and osteophytes. So this is osteoarthritis, and the bone deformities of the DIP and PIP, we call those Bouchard and Heberden's nodes. Okay, and this is due to overuse, so we often see it in elder patients, and it gets worse with more activity. Next, we have a patient with sudden pain and swelling in the big toe. We see needle-shaped negative birefringent crystals, and first we treat the pain with NSAIDs, and then we give allopurinol, which is a xanthine oxidase inhibitor, for long-term treatment. So this is gout. Then next, we have a patient with hemochromatosis who develops sudden pain and swelling of the knee, and we see rhomboid-shaped positive birefringent needles. So this is CPPD, calcium pyrophosphate deposition disease, also called pseudogout, and it tends to sometimes affect patients with liver issues, and here they like to compare gout and pseudogout, so remember the shape of the needles here. Those are very important. Next, we have a patient with middle-aged complaining of increased need for eye drops and new dental cavities, and it increases the risk of lymphoma. So this is Sjogren's syndrome, and remember this is an autoimmune condition, and they have antibodies against SSA and SSB, also called Rho and LA, and they get dry eyes, dry mouth, and on histology you see a lot of lymphocytes because it's an autoimmune condition, and over time this inflammation can cause lymphomas. Next, we have a patient with a red hot swollen knee, a fever, and increased white blood cell count. So this is septic arthritis. Next, we have a patient with joint pain, silver scaly plaques on the elbows and knees, as well as nail pitting. So this is psoriatic arthritis. Next, we have a patient who has joint pain after recent sore throat and fever, and they have trouble seeing and urinating. So this is reactive arthritis, and this condition tends to happen after some sort of infection, and then you can't see, you can't pee, and you can't climb a tree, known as the conjunctivitis, urethritis, and the arthritis. Next, we have a 22-year-old patient with low back pain that resolves with movement. An x-ray of the sacral spine shows fused vertebra. So this is ankylosing spondylitis, okay, and the imaging findings are also known as bamboo spine. And something really important here is that you want to monitor chest expansion to assess the disease severity. Next, we have a 33-year-old female with joint pain and a facial rash, and labs show low hemoglobin and high BUN and creatinine. So this is systemic lupus erythematosus, and very high yield. It's going to be these females that tend to get joint pain, the malar rash. It can also have a lot of other symptoms as well because it's very widespread. You can get renal issues, photosensitivity, ulcers, pericarditis. So if you see like a bunch of random symptoms, usually in like a female, tend to think of lupus for this, okay? And remember, you get antibodies against double-stranded DNA, Smith antibody, antiphospholipid antibody, ANA antibody can be positive, so look out for those features. Next, we have a patient with recurrent pregnancy loss, and they develop a new a DVT in the leg, and they have a high PTT. So this is called antiphospholipid syndrome. Next, you have a patient with stiffness in the shoulders and hips, high ESR and CRP, and it quickly resolves with steroids. So this is polymyalgia rheumatica. And remember here, it can also be associated with giant cell temporal arteritis. Next, we have a 45-year-old female with chronic pain in the neck, shoulders, knees, and feet, and they've had a hard time sleeping. So this is fibromyalgia. It's really common in females who are like age 20 to 50, and it's like a very chronic, widespread MSK pain. Sometimes I'll mention the patients have tender points, stiffness in these areas, so just look for very chronic, widespread pain. Next, we have a patient who has trouble walking up the stairs and getting up from a seated position, and there's endomysial inflammation. So this is polymyositis. Next, we have a patient who has trouble walking upstairs and getting up from a seated position, and they also have a skin rash now, and there's perimysial inflammation. So this is dermatomyositis, and remember, these two conditions have a high CK level, okay? The differences here is that polymyositis just affects the proximal muscles versus dermatomyositis affects the proximal muscles as well as the skin as well. And in polymyositis, you have inflammation with CD8 T cells versus dermatomyositis, you have inflammation with the CD4 T cells. Okay, so look out for those key features that differentiate them. And remember, proximal muscle weakness is typically in your shoulders and your hips. So, combing your hair could be a symptom. Getting up from a seated position could be a symptom. So look out for those features in the vignette. Next, we have a patient that develops a painful lump in the muscle after getting injured in a soccer game. So this is myositis ossificans. And here you get an injury and then bone develops in the muscle and it develops this painful soft tissue mass. Next, we have muscle weakness worse with repetitive activity, and at the end of the day, there's double vision and drooping of the eyelid. So this is myasthenia gravis. Okay, remember antibodies form against the postsynaptic acetylcholine receptor, and it can also be associated with a thymoma. Next, we have an elder male smoker with weight loss and a chronic cough who now develops muscle weakness that improves with activity. So this is Lambert-Eaton syndrome, and here we have antibodies against the presynaptic calcium channels, okay? And this is associated with small cell lung cancer. Next, we have a patient who's 45 years old. They develop heartburn after eating, and their fingers turn blue in the cold. So this is scleroderma. And remember, the difference between CREST syndrome versus scleroderma is that CREST syndrome just has the calcinosis, the Raynaud's phenomenon, the esophageal dysmotility, the sclerodactyly, and the telangiectasias, versus if you have other symptoms that are, affect different parts of your body, we call that diffuse scleroderma. And in CREST syndrome, we have an antibody against anticentromere versus in diffuse scleroderma, you have antibodies against scleroderma 70, also known as topoisomerase antibody. Okay, so look out for those features. And when the fingers turn blue, we call that Raynaud phenomenon. Thank you so much for watching. I hope you found this helpful. Like always, like, comment, share, and subscribe. Reach out if you have any questions, and I will be posting the dermatology presentations very soon. Thank you so much. We'll see you again. Good luck studying, everyone.